Hello and welcome to the second in a three-part series of slides on motivational interviewing for ND Counseling 3. I think this quote by Pascal best sums up the spirit of motivational interviewing when he said in 1623, "People are usually more convinced by reasons they discover themselves than by those found by others." Today we're going to cover several things. We're going to briefly discuss communication styles, and I say briefly because you've already discussed these in your other Counseling and Therapeutic Alliance classes. Then we're going to get to the heart of the matter for this presentation, which is about discrepancies and ambivalence. We're going to be talking about using the decisional balance sheet as a way of amplifying some of our ambivalence, and then end by talking about importance, confidence, and readiness. The first question we need to ask ourselves is, why do people change? Moreover, why do people not change? When you take a moment and think about the nature of change, what do you believe? Are you surprised like I was to find out that majority of people who stop smoking do so without the help of support groups or professional therapists? That a lot of people who quit alcohol do so again without the use of support groups, professional support groups, or without the help of doctors. When you think about change, do you think it takes a long time or a short time? Would you be interested in knowing that brief interventions yield similar, if not better, results than long-term therapy approaches in getting people to quit alcohol and drugs? When you think about change, what are the qualities that the practitioner or therapist must have? I think we already know about Carl Rogers and saying that the practitioner's nature and style create a condition that allow change, and those conditions are warmth, empathy, and genuineness. So when you think about change and when you think about your patients making behavioral change, what are the biases and beliefs you already hold? We're going to use the example of Steve, who is a 40-year-old man who is referred to me by his wife, with whom he's been married to for about 15 years. They had a 13-year-old daughter. His wife wanted him to see me because he had hypertension. He was pre-diabetic. His blood sugar levels were skyrocketing, or starting to, and he was 60 pounds overweight. Steve came to see me because his wife nagged him to do so. And his main concern was sinusitis, not so much the hypertension or diabetes. At least that's what he said at the onset. He has a family history of cancer, diabetes, and cardiovascular disease on both his mother and father's side. And when we did 24-hour diet recall, he ate cookies, cakes every day. There was some cookies and cakes. And he didn't really eat vegetables. He had breakfast and lunch often in his car, and worked at a minimum 80 hours a week. He was a manager for a big company, and he had to travel to different sites to check on his staff. So this is the person we're going to be working with for the most part. I want you all to know these stages of change: pre-contemplative, contemplative, preparation, action, maintenance, and relapse. You're going to see these every week. We're going to keep going over those. So when Steve came to see me, he thought he was going to originally talk about hypertension. Then we started talking about sinusitis as well. When I mentioned to him that it has been shown that food could be a causative factor in chronic allergies, he was surprised. He wasn't aware of this. He wasn't aware that gluten or dairy or any other food allergen could be part of the problem. Therefore, Steve was in pre-contemplative stage when it came to that bit of information. Whether he believed it or disagreed with it is a different matter. When he was talking about exercise and hypertension and being overweight and pre-diabetic and hypertension, he completely understood that. He was contemplative. He knew that that was a problem, and he wasn't sure he could do anything about it. At this initial visit, had Steve been in preparation, he would be looking for other information about change. What could I eat instead of gluten and dairy? Can we talk about other resources for exercise? I want to come up with an exercise plan. Planning is part of the preparation stage. In the action stage, Steve would be actively engaged in change for at least a few months, a month or a few months. And he'd be doing it, and we would just be ironing out the kinks in that. In maintenance, he had been doing this in true motivational interviewing with alcohol and drug rehab. It's usually greater than 6 months. He'd been maintaining this. And relapse, people just go right back to their old behavior. For Steve, if he had given up gluten or dairy for about a year and was doing better, and then something happened and he started eating gluten dairy and said, I don't think it had anything, I don't think it helped at all with my sinusitis, even though you have comments from him in your chart notes for the past year that he was doing better without it. That would be an example of relapse. He could go from relapse back to pre-contemplative, contemplative, or preparation, any of those stages. So let's talk about our requirements for motivational interviewing. Part of our requirements is the spirit of MI being empathetic. We have to be empathetic, not sympathetic. We don't pity patients. We don't feel sorry for them. We stand in their suffering. And in order to stand in their suffering, we have to understand their worldview. How do they view the world? Once we understand their worldview, it makes sense. We can empathize with them. So we'll be spending a little bit of time talking about the counseling communication styles that are particular for MI that you already know. The next part is that we empower patients. We empower patients by seeing them as an equal participant in this session. We don't belittle them. We don't patronize them. We don't leave the patient visit saying, he's just not ready to change. We understand, oh, they're in pre-contemplative stage. They're in contemplative stage. Okay, now I know what to do. To empower the patient, we see them as an equal. We know certain information. They know about their life. So to empower the patient, we also have to be unattached to outcome. We don't know what's going to happen. We hope for change, but we're helping them make new lifestyle behaviors. But we're helping them explore their life. They do it on their own time frame, not on ours. So we have to be unattached to outcome. To empower the patient and express empathy, we have to understand their core values, because their core values will speak to the dissonance, and I'll talk about that in a moment. How do they view the world? What do they value in life? And finally, we have to support their successes. We support successes by always looking at what the patient is doing well. One of my patients talks about it as cross-referencing. When he started looking at these skills, he would say, I can't give up this, or I can't change this behavior. I can't exercise every day. And he began to realize, wow, the skills that I had to change my diet, those skills that I brought to that are the same skills I can do to bring to exercise. So I do have the same skills, the mental, emotional framework skills, and I can do that. So we support successes by looking at what the person's already done. The other thing is, another way to look at successes is to notice that whatever behavior the patient's engaging in, say it's smoking, how is it serving them? When we help them identify that they're smoking as a means to take care of themselves, we can support their success. My God, you've had 30 years of trying to decrease your anxiety. You've been doing it with smoking, but you've been really trying to take care of yourself. Do you see that? Patients return to us only when their successes are celebrated. So how do we celebrate successes? So this is already a part of this expressing empathy. How do we express empathy? We express empathy by listening to the patient. But let's talk about a few more listening skills. In motivational interviewing, the acronym they use is OARS, and you know all about that, so I'm going to go through these really quickly. OARS, open-ended questions, affirming or affirmations, reflectively listening, reflecting, and summarizing. You already know the difference between open-ended and closed questions, and I don't want you to leave thinking open-ended questions are everything. There are times when we need to know direct answers. What is a dose of your hydrochlorothiazide? No. How many times a day do you take that? I want to know exactly, is it 3, 4, 5? So there's a difference between open-ended questions and closed-ended questions. They both have their place. However, the more open-ended questions we can use, the more information we can get from the patient. Affirmations are a little bit tricky. Affirming the patient. We want to support their successes like I mentioned earlier, but we do not want to become a cheerleader. We do not want to say, oh my God, yes, you can do it. As I said in the previous slide presentation, many times when we take one voice, the patient takes the other. If I start to say to Steve, you used to smoke cigarettes, you quit, and you don't smoke anymore, you can do this too. If the next thing out of his mouth is, yeah, but, that affirmation is not going to work. You want to support their successes, what they have done, and do so in a very positive way to help them identify, yes, they've done this, without sounding like you're trying to push them along and give them advice and cheerlead them. I know a lot of students and practitioners who want to applaud what the patient does, but you want to do so in a way that doesn't encourage them getting defensive. So notice if they start to say but and start to argue, stop. You'll just get into an arguing match with your patient. You already know about simple reflections. It's just repeating back, paraphrasing statements that reflect their thoughts and their emotions, and they help the conversation go along further. We have amplified reflections that can increase the intensity of what we're talking about. If you say something that's incorrect, your patients will let you know. If I said to Steve, you think it's impossible to eliminate gluten and dairy from your diet, he can say, no, not impossible. I could do it. Or he could say, yeah, that's it. I don't think I can. Tells you a lot. The double-sided reflection can be done with an and or a but. But usually negates everything you said before. And is less confrontational, and it talks about both sides of those things. So notice when your own patient says but. I often interrupt it after they say but and say, okay, you just negated everything else. Let's talk about that last part. So you understand double-sided reflections. And summarizing, just encompassing everything that was said before. When you do any of these open-ended or closed-ended questions, affirming, reflecting, or summarizing, really be directive in what you choose to discuss. Because what you amplify gets highlighted, it increases, and it could go down the wrong path. So just be very careful what you're looking for. And that's all I want to say about the OR skills. You've covered them in other classes. So let's move on to discrepancies and ambivalence. Motivational interviewing stresses that we look at resistance because it's a natural part of change. In the process of motivational interviewing, there's two stages or phases. The first is to build intrinsic motivation, and the second is to strengthen commitment to change. Steve was there because his wife asked him to go. Now, many times we can just negate that and say, oh, you're here for your wife, you're not here for you. That's extrinsic motivation. We can also amplify that and we can affirm that, wow, you must really care about your wife. Yes, I do. I really do. And I don't want her on my back, which is one of the things he talked about. So in order to help build this intrinsic motivation, we have to resolve ambivalence. As I mentioned, we have to look at the patient's core values, and we did that exercise in class on core values. There is only a problem, there's only dissonance, when our core values are not aligned with our behavior. If Steve says, I really want to be healthy, I want to support my health, and then I ask, do you think eating Oreo cookies in your car while you're going from job to job is helping with your health? And he says, no, there is the dissonance. Do you want to care about your family? And he says, I do want to care about my family. Okay, is the way you're treating your body, caring for your family. He might say yes. His wife says no. No, if he cared about us, he would do this. And that means that she should be the motivation. So we have to look at what our core values are and get that out of the patient. Help them explain what those are so that we can see how we can evaluate the behavior. We develop discrepancy by, again, looking at the core values and looking at our goals and our behaviors. And there's a difference in that how the person is living now and how they'd like to be. That causes discrepancy as well. So again, we elicit the goals and values, and we want the patient to become the instrument of change. We want them to argue for the change rather than our arguing for it. And as I've said before, if there's no discrepancy, there's no ambivalence, there's no need to change. So there's several types of discrepancy, and there's two right here, internal, external. There's also a discrepancy that can be between the patient and the therapist, which is a form of external. So when we talk about internal discrepancy, you already know one quite readily. The patient crosses their arms, looks down and says, "I'm fine." What their body posture is saying and what their words are saying are different. But discrepancies can also be what one says and one does. The patient who says that I have no problem with alcohol, and then says, well, every day they get drunk and they have to take a cab home, or they get drunk and they don't know where they are the next day. That's an example of the internal discrepancy. They say they really care about their health. I really care about my health, and then they do something like that. So there's several types of discrepancies, as I mentioned. Examples of discrepancies are also when my patient said to me, my son is perfect, but he doesn't respect me. What is that an example of? That's one of these discrepancies here. In my worldview, perfection and respect go hand in hand. I had a student once say to me, I deserve to pass this class. And the question was, because they didn't do any papers, they didn't take the quizzes, but they deserve to pass the class. That's an example of a discrepancy listed here. So you want to notice when you're working with patients, where are their discrepancies and where do they come out? Where do you see them in their conversation or what they say they're doing? Again, to know that, sometimes it's useful in knowing their core values. And when we see discrepancies, we call them out. We want to illuminate them. Few choices in life are ever done with 100% certainty. Rarely. And if you think back on your life, when did you make some decisions and you didn't have 100% certainty? One of the things we have to normalize for our patients is that it is a normal part of change. It is normal to have discrepancies. It's normal to have doubts and fears. There's a variety of conflicts that happen. This is part of our ambivalence. There's a variety of them that we see, and we just begin to notice them. There's the approach, the avoidance, and then, of course, on the next slide is the approach avoidance. So the approach is a great one. I wish you all have that when you graduate. For example, you graduate and you're offered 2 jobs in 2 great places, and they will pay your moving costs. And they're both near friends or family, so you feel really good about either. In one, if you work for them the first year, they'll pay off your student loan and give you a modicum of salary, so maybe like $25,000, but they'll pay off your student loan. In the second, they won't pay off your student loan, but your salary is $250, so it will cover your student loan payment, and you could almost pay it off. Both options are great. In the avoidance, it's the rock and the hard place. You have to choose between 2 evils. The example I think Miller and Rolnick talk about in one of their books is that you could either park far away and walk for a long time, or you can park really close but get a really expensive ticket. Now, in the avoidance, if any of you said, well, that's easy, I would just pay for the ticket, or some of you had said, I'll just walk, that's not a problem. What if you had a broken leg and you were on crutches? Again, so this is where you have to choose between two evils. Now, again, if you're the person who says, that is not difficult, I know what I would do, this is not your conflict then. It's not an avoidance conflict. The approach avoidance is the common one. It's where we feel two ways about something, and usually about drugs. We hate drugs, and yet they help us feel better, or when we're in a time of stress, we need that. Then when we move towards that, we feel worse. It's that going back and forth, where we feel torn between two things. The more we move towards it, the less enticing it is. The more we move away from it to the other side, the less enticing that side is. And Steve had this conflict with food. He felt bad about what he was eating from the hypertension and diabetes standpoint, but then when he avoided the food, he really wanted it more. The more he approached it, the more he felt bad about it. So approach avoidance conflict. One of the ways to help us with this is the decisional balance sheet, and I love to use this with patients. I use this with Steve and other people. When you're using the decisional balance sheet, you're looking at the pros and cons of two things, never just one. So I did this several times with Steve, and I'll give you an example. For Steve, I started talking about vegetables. He had this comment about vegetables. His wife loves vegetables, and he doesn't. When his wife is out of town, his daughter and he have pizza and cookies and ice cream. And his wife knows this. She finds it because she finds it in the garbage can when she comes back, and they always admit it sheepishly, but he does it all the time. So we talked about vegetables. I said, what's the benefit of change? What's the benefit of vegetables? Well, I'd be healthier, and I'd get my wife off my back. What's the consequence of vegetables? They taste, I won't use the word he said, they taste awful. They don't taste good. They don't taste good. So we don't stop there. We say this in several ways because when we say it in several ways, patients will often hear themselves speak. They'll find out more about what they're believing. So when I said that, okay, that's really interesting, but I'm saying, Steve, what is the benefit of eating the way you are if you just continue? What's the benefit of that? He said, it's easy. I don't have to do any work. I don't have to think about it. I don't have to do anything about it. I don't have time to worry about when I'm going to eat vegetables and have to go to all the places to do it. I can eat the way I'm eating now. What's the consequence of not changing and continuing? And he said, well, then I'll probably die of diabetes or a heart attack. Again, this is when he paused. I may have said this already. I had patients, as a patient, he said, did I just say that? And he heard himself. So listening to the consequence of not changing was really effective in getting him to hear himself. So I said, wow, so if you keep eating the way you're going, you're going to have a heart attack, but oh, vegetables are yucky and it's too much work. So as long as it's too much work, that sounds like you're not going to make any change. You can do this with anything. And that was just the first in a series of decisional balance sheets I did with him, looking at the pros of vegetables and the cons of vegetables. But there was also the stuff about cookies. What's the benefit of cookies? Well, the benefit of cookies is they taste damn good, he said. And the benefit of it is it helps me feel better. I feel better. My day sucks. And that's when we went into a lot of this about how he works so hard. He wants to not have to worry about things. He wants to give himself some reward. And that's the benefit of cookies. And we went through the benefits and the cons of everything as well. So when you're working with patients, what's the decisional balance sheet? Do you just stop short on one thing? The pro of exercise and the con of exercise, but not looking at the pro of whatever they're doing. If somebody's not exercising, they're specifically they're doing something, and what would that be? Staying in bed. What are they doing when they're not doing the behavior they want to be changing? So look at those pros and cons and do all four if possible. See what comes up. Then we begin to look at the importance and confidence. How important is this? How confident are you How confident are you that you can change? And are you ready to make this change right now in your life? Using just scales. Importance ruler. Using a confidence ruler. Combining them, how important is it for you to give up dairy? And how confident are you that you can stay away from it? Right. Very confident, not confident. So this is a 5 scale, the other one is a 10 scale, whichever one you want to use. It's helpful sometimes to keep it consistent and scale things with your patients. And we combine these then. Once you have both of these, we can put it into basically 4 patient profiles. The first is low importance, low confidence. Then you have low importance, high confidence, high importance, low confidence, and then high importance, high confidence. And I'll tell you, Group D is a great group to work with. When they think that the things to change are important and they feel they can do it, they take action right away. In my career, I've had maybe 3 patients for whom dietary changes were easy and they did them instantly. They were highly motivated, they were highly confident, and they thought the change was worth it. And that's only about 2 of the patients I've worked with in all my career with food. This is with food, not talking about some other changes. Now, when we have low importance, think about it. We have pre-contemplative, contemplative, preparation, action, maintenance, and relapse. Low importance means they don't think the behavior change is important. It's worthwhile. So, had Steve said that dairy, the food, changing his diet wasn't important, he didn't think it really mattered about his diabetes, he'd have low importance. He would give that low importance, and so he'd immediately be put into Group A or Group B. Now, interestingly with Steve, when Steve came in, he wasn't aware that gluten and dairy was connected to sinusitis. He didn't know that food allergies could be linked to sinusitis. He thought that some of the food he was eating, the sugar, the fat, that would link to hypertension and to diabetes, and the fact he wasn't exercising. So he gave exercise importance, but he had low confidence that he could exercise. Changing his cookie diet and pizza diet, he thought it was important for the hypertension, but he was not confident he could do that. He was pre-contemplative when it came to gluten and dairy, and then as we talked about it, he gave it some importance. He didn't give it enough confidence. When you have low importance, low confidence, or any time where there's low importance, the first task of the physician or practitioner, is to help raise doubts. Do you think this could be an issue? Here's some data. You do docere. You give education. You give information. If they don't take the bait, if they don't think that there's any importance to it, your job is done. Move on to something else. There's nothing else for you to do. This is where we have to be unattached. I had a patient once who came to see me after seeing 5 other practitioners because he was extremely exhausted. He also had a crystal meth habit of weekly binges on the weekend, followed by pot on the week to keep him mellow. And I remember simply saying in a very curious way, "Do you think that the crystal meth could be aggravating your fatigue?" He stood up, started screaming, pushed the chair aside, said, "I don't think so. I don't think that's what all of you want me to say. I don't agree. You got the problem," and on until he left and fired me. And I was in good company with the other doctors that he fired. He had low importance. He gave low importance to that, and he probably had high confidence because he did say on some other things, "Oh, I could quit smoking anytime I did it." That's what you'll hear with low importance, high confidence. "Oh yeah, I could quit smoking anytime, but I don't really think it's that big of a deal." Oh, and I hear a lot, "I could quit pot. Yeah, I could quit pot, but I don't think it really hurts me." So that's what you have. You'll hear low importance, they don't think it's a problem, and they think they can do it. That's high confidence. If they have low importance, low confidence, you just have to start with the importance part. High importance, low confidence, that's when we begin to build support that they can succeed. And what I like to do, the term I use from my patient, is cross-referencing. Help them identify other areas where they did succeed and can continue to succeed here. When you're working with your patients, where do they fall on this patient profile and to identify that so that you know that you're not just talking about the importance. They may say it's important, but if they don't believe they can change and you haven't asked about their confidence, you'll get stuck. This also comes into play when we give treatment plans. And I really want to stress this part. When we give treatment plans, I've seen many times when patients give treatment plans, they do it in a very directive way. Here, take this 3 times a day. I recall a time when I was working, subbing basically for another physician. The students were about to graduate in 3 weeks. 3 weeks till graduation. The practitioner was on vacation. I was subbing for them, and we were following what the treatment protocol was that they had outlined with their supervising physician. Great. I met the patient, and then the students came in to give the treatment plan. They started off with talking about some diet stuff. Then they started talking about adrenal glands. And we want to give you this. This herb would be really helpful for your adrenal glands, and that seems to be a problem. And we want you to take 2 capsules 3 times a day with food. They were about to proceed when I, watching the patient's body language, interjected. I said, "Excuse me, wait a minute. What do you hear about that? How is that for you?" The patient looked sheepishly at me, and the students said, "Well, I don't take anything 3 times a day." That's good to know. What would it be like if your patient had a treatment plan where everything was TID? They come back, maybe they don't want to come back because they didn't do TID. Some of your patients will say, "Hey, I don't like TID and I'm going to just take it twice a day." And they're fine with that. But some will feel like they did something wrong. The second thing she added was, "And I don't understand, I have this other problem. Why are you working on my adrenal glands? If I don't understand," she said this, "if I don't understand why we're doing this, I'm not likely to follow the treatment plan." This was good learning, although they were graduating in 3 weeks, so I don't know if they took that to heart. It's really important in giving treatment plans that we present it in a docere way. Hey, this is what we came up with. These are the things we're thinking. We see that the adrenal glands are really important for this condition, and so usually these are the herbs that people take. My supervisor, you can even say that, my supervisor really likes this, or I really like this herb, and I think it will be helpful. You can say that. But then there's the invitation. What do you think about that? Is that something that sounds interesting to you? This is how we can speak in a motivational interviewing way when we're talking about treatment plans. And we can access some of this important confidence from our patients. So this week, I want you to notice your patients. What stage of change are they in? Remember, one patient can be in several stages. You could have a patient who's starting to exercise and has been doing it for about 6 months now. Maybe they're in maintenance stage. They have hypertension and they really are taking to heart to exercise and lose some weight. But they are not committed to giving up sugar or alcohol or binge drinking. So it doesn't matter what the situation is. What's the problem and what's the behavior contributing to the problem? Which stage of change are they in for that specific thing? With all our patients, how are you expressing empathy? And notice if you are tending to argue or convince. Are you so impassioned about them changing that you really try to argue for change? Or you give them advice. Have you tried this? Well, have you tried this? Versus, well, what have you tried? What got in the way of that? That didn't work for you. So that's interesting. I want to know. That is different than, well, have you tried that? Well, how about that? Well, did you do it this way or that way? So notice your ors and your tendency to argue. When you're working with your patients, do you really know what their core values are? Do you know what their goals are and their core values? How do you find those out? And then, where is the ambivalence? Where is the resistance? See if you can identify the discrepancies, ambivalence, and conflict. How do you practice the importance, confidence, and readiness? And simply readiness is if they find that they're confident about it and they find it important, are they ready to do it now? Maybe they need to wait for something else. So please note where you're practicing these skills, and you can use this in writing your paper. Thank you very much for participating. You can now take the quiz that is on the Moodle, and next week we'll be talking about change talk.